Welcome, and thank you for joining us today for our Systems for Action Research and Progress webinar series. This is a series that we host usually 2 times a month, and it's a chance for us to hear from our research studies that are being conducted through our program about their experiences in conducting their study. They can share with us what they're learning so far, or in the case of this research project, they are near the end of their project, so they're going to be able to share a lot of their findings with us. And if you're not familiar with Systems for Action, we are a signature research program of the Robert Wood Johnson Foundation, and our focus is on funding research studies that focus on aligning health and social systems. And today we want to make sure that we give the chance for our audience to interact with our research team. So if you have any questions during today's webinar, please make sure that you post those in the Q&A box at the bottom of your Zoom screen, and we'll be sure to get to those at the end of today's session. And with that, I think I'll move into introductions of our research team, who will be presenting on their project focused on closing gaps in health and social services for low-income pregnant women. So we have Irene Vidianti, who is a data scientist for the Los Angeles County Chief Information Office. And prior to joining the Chief Information Office, she was a data scientist at the Department of Public Health. She received her PhD in Industrial and Systems Engineering from the University of Southern California and her bachelor's and master's degree in Information and Computer Engineering from Cambridge University. We will also be hearing from William Nicholas, who joined the LA County Department of Public Health, where he directs the Center for Health Impact Evaluation. And I will not be reading Will's entire bio here, but we will be including these in the follow-up email that we'll send that will have the PDF of all of these slides and also the recording from today. And then we're also joined by Kelly O'Connor-Kay, who is going to be providing commentary. She's the executive director who oversees the programmatic fundraising and marketing operations of Maternal Mental Health Now. And with that, I will turn it over to our team so they can share more about their research project.
Thank you, Carrington. So first, before we delve into the research itself, we want to start with an introduction of what MAMA's initiative is about. This is the initiative that we are evaluating in our research to see how it really addresses the needs of pregnant women in Los Angeles County in terms of its impact on various outcomes, including birth outcomes, justice involvement, social service benefit receipt, and so on. So first, I'll start with some background in terms of why an initiative like MAMA's is needed. Can we go to the next slide, please? So MAMA's initiative is hosted in Los Angeles County Department of Health Services, which is a network of safety net hospitals within the county of Los Angeles. There has always been poor birth outcomes in this population, which really necessitates a different approach. To illustrate, Carrington, if you can click. To illustrate, here's a graph of the low birth weight rates in Malawi, LA County, and LA County DHS. If you can click. So the rate of low birth weight in Malawi is 8%. In LA County, if you can click, it's 7%, which is slightly better than Malawi, not that much. But if you look at LA County DHS, the rate of low birth weight is at 13%. So, you know, it is far higher than what it is in LA County in general, but higher than Malawi, which actually has been named by the WHO as one of the countries in the world with the poorest birth outcomes. So I think that really tells you a lot about how poor birth outcomes in the safety net population is. And same thing if we look at another aspect of birth outcome, if you can click again. In terms of preterm birth. So again, if we look at Malawi, the rate is about 18%. For LA County, the rate is lower at 11%. But again, when we look at the Department of Health Services, the rate in this case is slightly better than Malawi, but not much at 16%. So again, this shows that the birth outcomes in this population really are poor and we need a different approach. Can we go to the next slide? So The, the approach that is being broached here is the need to address social stressors. And to do that, there is really a need to breach agency silos in Los Angeles County. So if we look at the graph at the bottom of the page, we can see that social stressors rate in the safety net prenatal population is really high. We see that the rate of substance abuse is about 1 in 5, intimate partner violence is about 1 in 3, housing instability is about 17%. So this is really a problem in the LA County DHS prenatal population. And social stressors contribute to poor birth outcomes as well as outcomes that are poor later in life as well. Because their social stressors are so common, there is really a need to offer comprehensive services and supports to address these social stressors alongside healthcare provision. So that's what the Mama's Neighborhood Initiative does. It assesses clients' needs in terms of all this range of social stressors as well as health needs, and connects clients to the needed services across the sectors, whether it be housing, social services, mental health treatment, and other services. Next slide, please. So the Mama's Neighborhood Initiative, the features of the program are actually embedded in the name. So MAMA stands for Maternity Assessment, Management Access, and Service Synergy throughout the neighborhood. And the assumption of the program that is built into the program is that there is a need for a comprehensive and coordinated approach that includes physical, mental, and social pillars of health so that we can address poor birth outcomes. So the features of the program include assessment, which includes screening and identification of what the needs and risks for the pregnant women are, including medical, social, and environmental determinants, management of access. So once the women have been assessed for needs and risks, the intensity of service provision is then aligned with what the identified risks and needs are. And then there's also service synergy. So there is connection to care across sectors, but this care across sectors is coordinated and collaborative to mitigate the determinants of poor outcomes, because there is a need to make sure that all the social stressors are adequately addressed. And this is also a very important component of the Mama's Neighborhood Initiative, that this is all done throughout the neighborhood. So the initiative goes beyond the borders of the clinic to the community with community-based partners, as well as through a home visitation model called Mama's Visits. Next slide. And in fact, this neighborhood is very diverse in terms of the services that they offer, the kind of population that they serve. So the Mama's Neighborhood Network includes mental health providers, intimate partner violence, counseling, housing providers, food security providers, substance use services providers, and so on, as you can see in this diagram. Next slide, please. So there is a need to understand just the impact of this Mama's initiative. How successful has it been? What are the impacts in terms of reducing inequities in the county? What are the impacts for the population of the Mama's clients in particular? So that's really what our research is doing. Next slide. So the three main research questions that we have are: what are the outcomes of the Mama's initiative? How do the program impact health equity? And how effective the cross-sector linkages that Mama's initiative does are? And we are answering those using 3 streams of analysis: quantitative, qualitative, and network analysis. Next slide. We are using a mixed methods approach, which blends quantitative, network, and qualitative analysis, as I mentioned. So for the quantitative analysis, we're using several secondary data sets. We're using a linked administrative data set called the Countywide Information Hub, which I will talk about more later, but it brings together administrative data from various county departments across sectors, including justice, health, housing, and so on. We are also using the MAMA's administrative data and also using birth records. So for the quantitative analysis, we are using difference in differences analysis of cross-sector outcomes to look at the impact of the MAMA's initiative on various outcomes outside of birth outcomes. So we're going to be looking at things like social service benefit receipt, justice involvement, mental health crisis rates, and so on. And we will be using difference in differences analysis for that. We will also be analyzing birth outcomes, and we will utilize match samples, specifically propensity match comparison group compared to the MAMA's treatment group for that. We are also using network analysis, and we collected primary data for that. We did a network survey of the MAMA's neighborhood community-based partner agencies. So the partner agencies in the community that you saw in that colorful graph showing the MAMA's neighborhood network. And then we created a network map of the partnership network with network scores based on that network survey. And we also have other insights from this network analysis. And finally, we also have a qualitative analysis component to our study where we are collecting multiple streams of primary data, including patient interviews, provider interviews, and key informant interviews. And the analysis is based on grounded theory. So that's a lot. And today we will be hearing, you will be hearing from us about results from all three. Some are more preliminary than others, and some are actually fairly complete. Next slide. So we'll start with the preliminary results from the quantitative analysis. Next slide. So I'll first start with the quantitative data linkage that we had to do with our secondary data. So we are using data from the Los Angeles County Countywide Information Hub. So this data set is an already linked administrative data set that connects together data from these various sectors and various agencies that you see here, from social services, housing, justice, mental health. And this data set will allow us to assess the cross-sector impact of the initiative. So we can, because it has data from the health and mental health sectors. For instance, we can look at healthcare and mental health utilization as well as crisis. Because it has data from social services, we can look at food assistance and income assistance receipt. We can look at housing and justice involvement. Click, please. And we linked the MAMA's administrative data through probabilistic linkage into this county-wide information hub. So we can do that cross-sector analysis of the impact of MAMA's initiative on these various outcomes. And we will also link birth records. Actually, this is already done to the information hub to allow assessment of birth outcomes. And we will use this array of linked data to construct a comparison group of non-participants that resemble MAMA's clients based on individual characteristics, birth risk factors, social determinants, and service utilization. So this will be done approximately in a month or two. So MAMA's has been growing over time, as you can see in this chart. Since its inception in 2014, MAMA's initiative has been steadily growing, and the number of clients have steadily increased. Click, please. And as is typical for a program that is rapidly growing like this with changing needs, there are also different implementation models. So the implementation model of MAMA's really has evolved over time to accommodate different needs and to improve the program. It's really in mid-July where the current implementation model really was implemented in MAMA's. Click, please. And because of that, we are going to be restricting analysis to MAMA's clients who enrolled in only 2 years, in 2017 and 2018. The lower bound is of the date starting in 2017 is to ensure that the program has been fully implemented so that we are removing bias from the changing implementation of the program. And the upper bound of this date parameter is such because we are looking at 1 year post-enrollment outcomes. And we all know that COVID changed things quite a bit. So we want to make sure to remove potential effect of COVID in the 1 year post-enrollment analysis, which is why we're only looking at 2017 and 2018 enrollment for this quantitative analysis, although you will see in the network and qualitative analysis that we will actually be looking at COVID effects. Next slide. So in terms of the analysis sample, we excluded MAMAS clients who we cannot match to the countywide information hub or are poorly matched to the countywide information hub. And we also excluded people with multiple enrollments that within the 2-year period that we're looking at. So there is a small sample of clients who enrolled multiple times, and we removed those. That leaves us with about 3,600 unique MAMAS clients for analysis. Next slide. So here's the results of our preliminary analysis for the cross-sector impact of MAMAS. As you can see, we look at the impact of the MAMAS initiative on income assistance, food assistance, justice, mental health, and health. So we look at the pre-post results. So we look at what the rate of income assistance, for instance, was 1 year before enrollment in MAMAS. And then we look at the rate of income assistance 1 year after enrollment in MAMAS to see if there has been improvement. So for income assistance, we're looking at CalWorks and GROW. Those are the programs in California for income assistance. And we did see that there is an increase from the pre-enrollment to post-enrollment from 1,200 to 1,800 clients. So now we have about half of the MAMAS clients enrolled in income assistance, which is desirable because the MAMAS neighborhood clients generally are medical clients who are eligible for income assistance. Same thing with food assistance. We look at CalFresh, which is the California implementation of SNAP, or Supplemental Nutrition Assistance Program, and we also see a marked improvement in the rate of receipt of food assistance. We also see reduced rates of arrest, reduced rates of mental health crisis, and reduced rates of ER visits. So for this cross-sector impact analysis, we are going to be adding a comparison group to the analysis so we can look at this pre-post outcomes as compared to the comparison group. And we will be doing difference in differences analysis, so that's forthcoming. And we are also going to be looking at birth outcomes and the impact of MAMAS on birth outcomes, as well as whether there are changes, whether there are impact on inequities in birth outcomes. So those are all still in the works and are forthcoming. Next slide. And then we also have some really interesting results from our network analysis. Next slide. So first, we started with having MAMAS staff identifying what organizations are part of their MAMAS neighborhood network. MAMAS staff identified 51 organizations with 11 healthcare organizations, 35 social service organizations, and 5 public health organizations as part of the network. And then we compiled contact information of key staff from those 51 organizations, but we were only able to compile 40. So those 40 members that we have contact information for were invited to participate in a social network analysis survey using the partners tool. And 19 members responded for a 48% response rate. This is a response rate that is lower than we would have liked, but we have heard from our partner, Visible Network Labs, that conducted the survey that during the COVID era, this response rate is actually quite common. Out of the 19 members that responded, respondents collectively had 80 partnerships, and those 80 partnerships are you can see that in the network map that we have on the right-hand side of the slide. So the network map that you see on the right-hand side of the slide shows the agencies, which are represented by circles or nodes, and the relationships are represented by the lines and arrows, directional arrows showing who refers to who, for instance. And we also have the bigger node sizes representing more connections, and the colors of the nodes represent the different sectors that the agencies are primarily in, whether it's healthcare, public health, or social services. So just looking at the network map, you can see that the network is quite diverse, but there is a low level of density. So there is a lot of connections, but you don't really see a very thick, you don't really see like this very thick forest of connections in the map. So that means that there is little connectivity already taking place, and there is opportunity to develop additional connections between members. Next slide. We also looked into trust and value in the Mama's Neighborhood Network. And the good news is we see that the members of Mama's Neighborhood Network reported high levels of value and trust within their network partnerships. So the scores that you see on the right-hand side are out of a scale of 4. And 3 is considered a healthy score. So you can see that in terms of trust and value and various components, Mamas is fairly healthy. Although you can see that for openness to discussion, which is the second component of the trust score, it is only slightly higher than that healthy range. So openness to discussion seems to be an area of growth within this network. So why is this important? High levels of perceived value and trust in network relationships are important because we want to make sure we can build and maintain the collaborative capacity, which is important in this neighborhood network. Value, in particular, understanding the perceived value, how the different members of the network perceive the value of the network. It's important in leveraging the different ways in which members contribute to the network and making sure that all of them see the value in contributing and getting back from the network. And trust is also really important because that facilitates effective information exchange and decision making. And when you have a collaborative network with so many members, it is also more efficient if there is trust, so you can reduce duplication of effort in the groups. Next slide. We also look at relationships among the network partners. So if we take a look at the chart that we have on the bottom left-hand side of the slide, we see that there are different types of relationship among network partners, starting from attending meetings together, a more cooperative relationship, coordinated relationship, and integrated relationship. So it's the connections in the network, neighborhood network here seems to be distributed across the levels. Our intuition is probably that more network connections, so relationship that is more coordinated or integrated, indicate a better functioning network. So maybe there is room for improvement there. But there is also a need to note that that approach is also more resource intensive. So if this network wants to move towards having more relationships in the coordinated and integrated relationship levels, then those will require more resources to maintain, and that needs to be in place at the same time. Additionally, we also look at what kind of relationships the various members in the network have with each other, and that's shown in the graph that we see on the right-hand side at the bottom of the slide. So most of the relationships are in the form of client referrals. less so in terms of information exchange and data sharing. And this is actually borne out also in some of the results of our qualitative analysis, which my colleague will go through later. Next slide. We also looked into MAMA's success in fostering cross-sector collaboration, and it does seem that MAMAs have been fairly successful in doing so. So we looked at various aspects of cross-sector collaboration, whether it's infrastructure or more process-based, such as shared tracking system, referral follow-up, and so on. And as you can see on the chart, there is a lot more of the yellow, orange, and purple colors that indicate somewhat successful to very successful in this chart. So it does seem that MAMAS is doing fairly well in fostering cross-sector collaboration, although maybe there is room for improvement in some aspects, such as shared tracking system or database, for instance, and referral follow-up and care coordination. Next slide. Since we launched the survey in the midst of the pandemic, we also wanted to take the opportunity to look into network resiliency during the pandemic. So we actually added a few questions before launching the survey, because we wanted to see just how the pandemic affected the network and how resilient it is. It does seem that this network is fairly resilient, and many relationships are unaffected or strengthened by the pandemic. So if we look at the chart, I highlighted in green boxes the responses that indicate that relationships are either unaffected or strengthened by the pandemic, and I highlighted in red responses that indicate that relationships actually weaken because of the pandemic. And as you can see, only 9% of responses indicate that the relationships are actually weakened by the pandemic, whereas the rest are saying that the relationships are unaffected or actually strengthened by the pandemic. So I should caveat this by saying that it is also possible that the respondents that respond to our survey are the ones that are more resilient, and that is why they are able to respond to our survey in the midst of the pandemic. So that is also a possibility. Next slide. We also saw that services that are offered by the network change during the pandemic. So if we look at the green box that looks at food security and food support services, we see that there's a lot of people who, so about 40% of the respondents said that they provide the service slightly more, and the rest say that they provide the service the same amount. So it indicates that there seems to be more need for food security services, and members of the network has responded accordingly in providing more food security services. On the flip side, if we look at the what is in the red box, home visitation services, we see that 50% said that they provide the service the same amount, but 50% said that they no longer provide the service. So I think this is understandable during the pandemic that they reduce home visitation services to protect the staff as well as people that are visited in the home visitation from exposure to the pandemic. So this kind of shift of services, I think, reflect the changing needs and the need to maintain reduced risk levels during the pandemic. And I think that is another sign of the network resiliency and flexibility during the pandemic. And next slide. Now I'll hand this to my colleague Will, who will talk about the results of our qualitative analysis.
Great. Thank you very much, Irene. Appreciate it, and good to be here today. Thank you all for joining. So yeah, I'm going to review results of our quantitative analyses. If you put the next slide up, please. So I'm going to focus on results today from our patient and provider interviews. As you heard from Irene earlier, we also are conducting key informant interviews. We're almost done with those. And I'll speak a little bit more about those because we are fortunate to have one of those key informants with us today to provide some commentary. So I'll talk a little bit about those interviews when I introduce her. Let me start by saying that these interviews, I'll be reviewing the results, but the interviews were conducted by the Southern California Center for Nonprofit Management. They have a great qualitative research team there. We work collaboratively with them on the development of the tools and instruments. But again, I'm presenting the findings that they've written up for us today. Also, we had originally planned to do focus groups, but that's another kind of example of the impacts of COVID. We had to kind of shift pretty quickly to doing phone interviews due to the pandemic. So we had aimed to do, as we shifted to interviews, we aimed to do 20 patient, 20 provider interviews. We ended up doing 20 patient and 18 provider interviews. Let me talk a little about who was interviewed. So among those 20 mamas patients that were interviewed, 8 were conducted in Spanish, 12 in English. All interviewees identified as either African American, Black, or Hispanic Latina. Their tenure in the program ranged from 4 months to a little more than 5 years. These were all highly impacted folks. Patient experiences included things like homelessness, incarceration, domestic violence, substance use disorders, and high-risk medical conditions. And we got representation from all 4 geographic areas targeted by MAMA. So we have LA County is we have 10 million people in the county. It's a very large place, and so the program takes kind of a geographic approach with centers located in four parts of the county. And we were able to cover all those. In terms of provider interviews, they were split between what we call the neighborhood care team, which is the core MAMA staff, which consists of care coordinators, social workers, RNs, nurses, and health educators. And then we also did some interviews with the physician staff on the program. And again, we also got representation from all 4 of the geographic areas for those interviews. So next slide, please. All right, so what were some of the guiding questions real quickly? From the patients, we really wanted to learn about their perceptions of their experiences with the various components of MAMA's program and the services delivered. We also wanted to get their perceptions of factors that might affect those experiences and their engagement in the program. From providers, similarly, we wanted to get their perceptions of the various MAMA's program components and also the factors that they saw as affecting patient engagement with MAMA's and also factors affecting patient outcomes. Next slide, please. So before I kind of go into the findings, it's important to start with a little context. You've got early on, Irene kind of gave you an overview of MAMA's, but particularly in response, I think ahead of time, we got a few questions from people who would be participating today, and folks wanted to know a little bit more about the kind of the nitty-gritty of the program. So what it looks like from the perspective of the patient, and also since we'll be talking about, a lot of the questions in the interviews have to do with these components, so it's helpful to kind of know a little bit about them ahead of time. So the patient intake process is often described by the providers as kind of the cornerstone of the MAMA's neighborhood program. It's very lengthy. It contains many sensitive questions. There's a psychosocial intake and a medical intake. Though that intake process results in a patient risk score. This is kind of the crux of the risk stratification approach that this program takes, which is one of the things that makes it unique. Very careful in assigning risk scores. Patients are assigned to high or medium or low risk groups based on their scores. And then there's a whole series of psychosocial referrals that are made based on the results of the risk assessment. And then mostly the high risk patients, but some medium risk patients also get enrolled in kind of a subcomponent of the program called Mama's Visits, which is a home visitation program. The medical intake is conducted separately from the psychosocial intake by a nurse. Medical risk is also factored into the global risk score that's computed. And then patients get grouped also in terms of their medical risk. So the high-risk medical patients get assigned to a high-risk OB clinic with more frequent visits, more intensity of services. Then there's a mid-risk patients that are assigned to intermediate OB generalists, and then low-risk patients receive care from midwives or mid-level clinicians. Another key part of the program are what they call the collaborative care meetings. These are regularly scheduled, another sort of cornerstone of the program. At each of these meetings, they're regularly scheduled. They're attended by all of the disciplines involved in the care of the patients, including the clinical staff, what we call the neighborhood care team, and then auxiliary providers who are providers that may not be in-house but are part of the network. And many of those are the folks that you saw in the network map that Irene shared. And so these collaborative care meetings facilitate communication between the neighborhood care team, the auxiliary care providers, and the clinical care team. All right, so with that background, let's look at some of the findings. Next slide, please. Okay, so first we're going to talk about the intake process. Overarching finding there was that the psychosocial intake should prioritize confidentiality, taking into consideration the virtual and in-person circumstances. Given the sensitive nature of the interviews and the length, it was important to find a private space. Most of the clinics had that. Some didn't. That could be a challenge, but finding at least some place, apart where people could feel free to speak confidentially. Another COVID challenge was that a lot of these intakes had to now be taking place on the phone, and they had to be concerned with, what was going on in the home environment, making sure that people were in a place, which is often hard. People living in crowded households to find a place where there's some privacy, but they found that what really helped a lot was letting the patients know ahead of time what to expect, not only in terms of getting them to find a sort of a private space, but also to expect some fairly sensitive questions in a fairly lengthy process. We heard from providers that having separate psychosocial and medical intakes was beneficial because it helped the patients build rapport with both sides of the house, the psychosocial care team and the medical care team. They may have revealed things in one intake process that they didn't in the other, so more helpful information was gathered. But patients did mention that it was a lot. There was a lot of time taken. It was a lengthy process, so there's a bit of burden there. But again, this is again seen as a critical cornerstone of the program, and overall viewed as helpful and beneficial. So the patients valued and appreciated the time and attention, and providers felt in particular that it helped. They used the time to help patients understand and navigate their care more effectively. And so this is just one illustrative quote that I thought was helpful in this case. This is from a patient. I think that's why it took longer for the appointments, but I see why, because I'm sure that all the moms had a bunch of questions and she would take her time. She wasn't rushing through every single person. If she did that, then part of the customer service wouldn't be as good. But you can tell she was dedicated and she really loved her job because she would take the time. Next slide, please. Now we'll talk about the collaborative care process. I talked a bit about those collaborative care meetings. Pretty much universal feeling among the providers that these meetings strengthen the professional relationships among the care team members, encourage better communication, and improved care. Folks talked also, even beyond those regularly scheduled meetings, having mini huddles even in between the collaborative care meetings to prepare for certain patients that were scheduled to come into the clinic. We heard a lot also that collaboration was facilitated by having all types of providers under one roof. That was not possible. It's just not the situation in all 4 of the sites, but it is in some of them. Open communication among the care teams allowed for rapid scheduling of patients needing urgent care. And so I mentioned here prenatal care triage. That's the term that was used by one of the providers, in the sense that they were almost able to use a kind of a triage model like you would see in an emergency room, where by the nature of them having good communication among the team, if they got an emergency call from a patient who really was in trouble or needed to be seen, they could bring them in and basically perform a type of triage within the context of their prenatal care clinic. And then a quote from a provider here that I think is illustrative. The nice thing about having the Monmouth program in our clinic and having wraparound services is that you don't have to send them to a different clinic or different site for these things. I know the social workers really well. I can just walk over to their office or call them and say, so-and-so is here, she's really struggling with this, can you come talk to her? I can walk over to our care coordinators, I can walk over to the medical legal people and say, hey, she's wondering how the application for that housing thing's going. And so everybody is right here in our clinic. All right, next slide, please. Little talk about referrals. This is, so effectiveness of the referrals process will be gleaned really depended on a combination of things. The availability of referral services in-house, again, repeating that theme of really being helpful to have in-house services. Then, given that we were dealing with sites around different parts of the county, having resources available in each community, so there's some variation in terms of resource availability by community. Universally, you know, we have a housing crisis here in LA County and a homelessness crisis. So housing resources were universally viewed as scarce in relation to need. So housing was a particularly hard need to meet. But what I've underlined here and bolded is the relational skills of the Monmouth care coordinators. That's really what came across kind of loud and clear, is that it was really, it came down to the person. They had really some really effective care coordinators, and their ability to develop referral networks and their relational skills were really what drove the effectiveness of the referral system. And in fact, so, you know, there was, what also came to light is that this reliance on the relational skills of the care coordinators led to a great deal of discretion on their part. And this was due really to a lack of uniform systems of referral and follow-up. So, and I think, as Irene said, this really kind of dovetails nicely with what we saw in the network analysis, which is that, you know, there was evidence of very strong collaboration across the sites in terms of their, you know, referral networks. But when it came to actually exchanging information and exchanging data, that's where scores would tend to be a little bit lower. So, but nevertheless, the trust is also there. So sort of some of the building blocks are there to, you know, create some more systems like that. You know, remains to be seen whether that, you know, that might, you know, improve things even more. In response to an interviewer question, are there ways that you confirm whether a patient has completed the referral? One provider said, I just basically rely on either a social worker or the care coordinators to report back to me, or at the collaborative care meeting to give an update on if the patient was able to connect with what we had talked about, or at the next time I see them for their OB appointment, we check in about that. So, you know, connections are being made. I mean, these are a very relationship rich care model, but it is somewhat informal, based on, you know, on phone calls and conversations, less on sort of formalized systems. Next slide, please. Finally, this last theme I'll talk about is about patient engagement and retention. Obviously, a big challenge with a heavily impacted population. But as you might expect, some of the reinforcing factors for patient engagement and retention included just building trust, right? By listening carefully and purposefully, providing safe spaces, and attempting to instill confidence in patients to manage and navigate their care. There was talk about the importance of the voluntary nature of participation and lack of behavioral requirements. I think this is interesting. There was a question ahead of time about substance use among this population, and how it was dealt with. One thing they found is that, and this is true, I think, among other, I'm reminded of work I've done in the homeless services field, is that not requiring, for example, that people change their behaviors. I mean, this, there's being open and saying that your participation in the program is voluntary. We're not going to sort of force you to do anything. Is apparently was a helped people to sort of stay engaged, because they felt like they had some agency around that. There's also there was an incentive program that helped. It's called the Baby Boutique. So there were certainly materials and things for babies and supplies and things that was a draw that was helpful. And then just this theme of making active and maintaining active and persistent communication with patients. So, keeping that balance between bugging people and just staying in touch. I mean, people's numbers change, keeping track of their contact information is really important. So just, constant, just making sure that you're staying in touch. That people need that connection. In terms of the barriers, really the barriers can be summed up as it was really the high risk status and the life stressors experienced by the patients that were the barriers. That's why the program exists, but it's also what makes it hardest to keep these women engaged. So the things that I mentioned that the women interviewed were experiencing, things like housing instability, justice system involvement, substance use. Here's a quote from a patient who said, "They helped me a lot because I'm a recovering alcoholic as well. Being able to open up and talk freely about those things helped me turn my life around and realize that I have to be a sober parent because the other parent for my older kids is not. They gave me strength. They gave me hope." Here's a quote from a provider about a patient who was a substance user, or I think it's just generally about the theme of substance use among the patients. We've had patients who are using, who've been placed into substance use disorder treatment facilities during their pregnancy and been able to actively manage their withdrawal and get them on Suboxone in the pregnancy and take care of them and their baby. And I think we've had a number of success stories like this where high-risk moms have been able to really stay connected with prenatal care. So, despite some of these life stressors being barriers, there are success stories. That's why this program exists, and they do have a success record with getting folks treatment for services. Next slide. All right, so let me talk a little bit about the next steps. We can move on here. So as Irene said, we've done some preliminary analyses, doing some pre-post analyses of some of these cross-sector outcomes in around mental health and housing and substance use and et cetera. But now we're kind of in the thick of constructing those comparison groups so that we can actually do the comparison group analysis, which is really kind of the gold standard that we're after. So we're going to, once we finalize that comparison group, which is very complex, we're going to analyze the birth outcomes, and we're also going to do that difference analysis of those cross-sector and outcomes that Irene shared. So not just pre-post, but also doing a comparison group analysis. And then with the birth outcomes, we're going to look specifically at how the program impacted disparities in birth outcomes. Around the qualitative analysis, we're going to finish up and do the analyses of our key informant interviews, which I'll talk more about in a minute. And then really what this is all about, just like assistance for action is about looking across sectors, we really want to look across our different methodologies and look for triangulation of effects of findings. We've already begun to see some common themes between our qualitative and network analysis, but once the quantitative analysis is done, that's what we really want to do, is kind of dig in more deeply and look across the various methods in this mixed method study. Next slide, please. All right, so gosh, I went longer than I thought. Boy, I better speed up here. Okay, just a thank you to the teams, the Mamas team, our team, the team at Southern California Center for Nonprofit Management, Visible Network Labs, who did the network analysis. Great thanks to all of them. And next, please, I'm gonna pass it over to Karen Kay. So just a quick introduction. So as I said, we did key informant interviews. Really the purpose of those was to go beyond the way the services are working on the ground in terms of bridging those sectors and looking at higher level kind of leadership in those sectors to figure out what's happening at the policy and systems change level that the Monmouth program and other programs like it can take advantage of, and how they should also be operating at that sort of higher policy and systems change level. So without further ado, I'm going to pass it to Karen Kay, the Executive Director of Maternal Mental Health Now, who's going to be representing the kind of mental health sphere.
Thank you, William, and thank you for that presentation. It was super informative. Maternal Mental Health Now is an LA-based nonprofit organization that's dedicated to removing the barriers to the prevention, identification, and treatment of perinatal mood and anxiety disorders. And clearly, Mama's Neighborhood is a program of great interest to us due to the fact that it's addressing stressors during pregnancy, and stressors during pregnancy, leads to depression and anxiety, and depression and anxiety during pregnancy is the #1 risk factor for depression and anxiety during the postpartum period. So in my role as Maternal Mental Health Now's Executive Director, our key programs are training and capacity building for healthcare, mental health, and social service providers on how to recognize and respond to depression and anxiety during the perinatal period. We do some advocacy work, which is all about increasing access to care. And we do public awareness work, which is all about reducing the stigma, which is one of the greatest barriers to care. We don't do direct service, we take a systems change approach, and our vision is that every new mother or birthing person that is affected by depression or anxiety receives timely, informed, and culturally appropriate treatment. So I served as, I was interviewed by Maura as a key informant interview for this project, and what I learned today, listening to the quantitative and qualitative data that was collected, is that it's very, I think it's very accurate in terms, it reflects the user experience of a user in Mama's Neighborhood, of a client or a patient that's been involved in the program. But something that I think is missing, and from the storytelling, or from the story that was painted, and that Maternal Mental Health Now is focusing on moving forward, is the user's voice. Like, I'm glad to see that there were patient interviews included in the qualitative part of the research. But I'm curious, like when Irene presented the slide on cross-sector impact, and used different data points such as CalWorks and CalFresh to speak to income assistance and food accessibility. If the client or the patient could recognize that as a positive outcome of their involvement in the program. And then also, that was really interesting to me, was the slide on the Mamas Network, and the fact that the majority, there's a lot of organizations out there serving this population, but the majority of them are simply referring out to each other, and a much smaller minority of them are actually sharing data and following the patient through the care pathway, and that is very true. Like, I see that every day. It's a very, very fragmented system. And while the network partners had high levels of trust and value in each other, I'm curious about what the patient's level of trust and value in those network partners were. So all that to say that Maternal Mental Health Now has a Los Angeles County Maternal Mental Health Resource, which is a traditional resource directory where someone can find a perinatal mental health resource, search fields such as zip codes and languages spoken, insurance accepted. We are in the process of completely replacing that resource directory with a more community-driven resource directory, which is powered by a group out of the Bay Area called Streetwise. And the goal of this resource directory is to ask community members, what was really of value to you during your pregnancy or postpartum experience? And that could be, it could be a mental health care provider, but it could also be just a group of moms that gathered in the park for a walk every Monday morning, or it could be their hairdresser that, you know, serves as an informed, someone just to speak to, or it could be any number of things that we're not even anticipating. And the goal of this new platform is to capture the community voice and identify the community level assets that are in the community that are kind of serving as a patchwork solution to providing care and support to the perinatal patient. So that platform will be launched January 1st. And with that, I'll leave time for questions.
Excellent. Can people hear me?
Yeah, we can hear you well.
Just quick, it's Street Vibe, is that the name? You said that's what it's based on from San Francisco, this director?
Yeah,
is that what you're calling it?
Streetwise, W-Y-Z-E. And they describe themselves as a Yelp and a Waze or a Fitbit for social determinants of health. This will be the first time that they apply their platform to perinatal issues and Los Angeles County.
I think we will be really interested in hearing what comes out of that. But yeah, I just wanted to respond to one of the points that you brought up about the lack of data sharing among partners. And as you have mentioned, from your perspective too, that is something that you have actually observed. And that is something that I think has been bemoaned as a deficiency among our county partners as well as outside partners as well, in terms of maternal mental health in particular, because of the mandate to screen every pregnant woman for depression. We have seen that there is tracking for screening, and the rate is sky high. And in fact, in terms of referral, mamas also track the referral rates for those who screen positive for depression, and the rate is also almost 100%. But what is not tracked is whether that referral is actually closed, whether people actually go to treatment, and then like what happens after. And I think that has been addressed as a deficiency. I think there are some ongoing efforts to try to tackle that. Maybe not at an extent where we can really truly really see the closed loop referrals across all the neighborhood network, just because there is a very diverse set of capability, data maturity, system maturity across all the various network partners. But I think that is something that is really important to tackle, and maybe this streetwise model might be an important component in tackling that. Sorry, Carrington, back to you.
Okay. That's great. I really appreciated Irene and William, you providing updates on your project, and Kelly for you joining and providing commentary. And we do have 3 minutes left for questions, so we'll see what we can get through. But I don't want that to hinder any other questions that you might have as an audience. So if you do have questions, make sure you put them in the Q&A box. And if we don't cover it today, which I imagine we won't, we'll make sure that we capture these questions, and we'll follow up via email to make sure that those are answered. So my first question I'm going to direct to you, Irene and Will. What metric is used to obtain the risk score for patients, and is current drug use part of that risk score?
So mamas use several risk domains, 9 in total, to calculate the risk scores. So the domains are drug use, tobacco use, interpersonal violence, social support, housing instability, food insecurity, general anxiety, and depression. And there's also the medical obstetric high risk factors component. So the risk level is assessed in each of this risk domain, and then the global risk score is determined from the risk levels across these domains. So as you can see, drug use is, and current drug use in particular, is actually part of that risk score.
Great, thank you. I think we have time for at least one more question. We'll see how quickly we can get through this one, but this one is in relation to network trust and values scores. So can you tell us how you arrived at the scores for trust and values for the Mama's Neighborhood Network, and do these scores vary by organization type?
So the network survey that we conducted measured value and trust between network partners using 3 validated dimensions for each concept for trust and value. And then survey participants assessed each of their reported relationships with other members of the network on these dimensions using a 4-point scale from 1 to 4. So an example of the question for one of the dimensions is, to the best of your knowledge, to what extent does this organization contribute resources towards efforts to refer patients between healthcare, public health, and social services to address unmet social needs, using that 4-point scale. In terms of the variability across organization types, that is actually not an analysis that we have done yet, and I think that might be an interesting thing to see if healthcare versus public health versus social service organizations actually report different levels of trust and value scores.
Great. Finished right at 11 a.m. on the dot, Mountain Time. So just to be respectful of everyone's time, I think we'll go ahead and close out today, but we'll make sure to email everyone that attended today with a link to the recording and the slides, and we will also follow up to answer any questions that we didn't have time to get to today. And then the last thing that I want to say is that we do offer a certificate of completion. So if you would like to receive one of these, there will be an opportunity for you to fill out a survey as soon as this Zoom session is over, and you can fill that out and alert us that you want a certificate of completion, and we'll make sure to get that to you in a timely manner. So I just want to thank our team today for providing an update on their project. You do have some other exciting analysis that's coming up in the future, so we'll have some exciting stuff to share about this project in the coming months. And Kelly, I want to thank you again for joining to provide commentary, and just thank you everyone for attending. I hope you enjoy the rest of your day.
Thank you. Bye.
Thank you to the S4A team too.
Of course.
Thank you. Yeah.